Okay, so the title of today's talk is Advances in Breast Cancer Treatment. A little bit about who I am. I'm a general surgeon. I do all of the breast surgery here at Memorial. I've been at Memorial for a little bit over 2 years now. I'm a member of the American Society of Breast Surgeons, whose aim is to keep surgeons up to date on newer techniques, advancements in breast cancer, mainly from a surgical perspective. I'm the representative for surgery on our committee for the Commission on Cancer. I'm also our tumor conference surgical liaison who meets weekly to discuss all cancer cases that are performed here at this facility, and member of the Cancer Steering Committee here at Memorial. So we're going to start out with some facts about breast cancer. I think this slide has a big impact because if you look at these numbers, you can truly see how many women are affected by this disease. So 270,000 new cases of breast cancer will be diagnosed in the year 2019. And 1 in 8 women in the United States will develop breast cancer in her lifetime. Men get breast cancer too. Their incidence as compared to 1 in 8 in females is 1 in 1,000. So it does happen. Obviously, it's much, much less common. 40,000 women die each year in the United States from breast cancer. So this disease affects a lot of women. I think in a room of this size, most of us know someone, first-degree relative, friend, who have gone through breast cancer diagnosis and treatment. So a little bit of background just to kind of set the stage for the talk, because when we talk about breast cancer treatment, you kind of have to have the background of what is breast cancer and where does it come from. So this is just a pictogram of the breast. It's kind of a cross-section. Here you're looking at the ribs. This is your chest wall muscle known as the pectoralis. And then this is the breast. Here you have fatty tissue of the breast. And then this is kind of the meat of the matter. Here are the ducts and lobules of the breast. And this is where breast cancer forms. Some synonyms for breast cancer are infiltrating ductal cancer or adenocarcinoma of the breast. They all mean the same thing, which is a tumor that starts in the tissue of the breast. So what is breast cancer? So we have normal cells all over our body, but specifically to breast, this would be a healthy breast cancer cell. Then something happens. Something in the DNA of this cell gets changed, mutated, and then you get this cell. It looks different, it acts different. Here you have a breast cancer cell, becomes mutated, and what that mutation usually means is uncontrolled growth, and that uncontrolled growth becomes a tumor. So tumors arise in the breast. They can arise anywhere in the female breast. Their pathway out of the breast is through lymphatic channels. Represented in this picture are these green little lines, and these are lymph nodes. So a tumor that starts in the breast can gain access to these channels. The first place a breast cancer will spread to is the axillary lymph nodes on the same side as the cancer. So here's its mechanism to get out. Once the cancer's here, it can then gain access to blood vessels and lead to other parts of the body, the liver, lung, bone, and brain, and that would mean advanced stage disease. So our goal is to catch breast cancer when it's here, okay, localized to the breast. So how do we find breast cancer? So mammogram is our main modality for screening for breast cancer. It is about 85% sensitive to detect breast cancer, meaning if you have cancer, 85% of the time, a mammogram is going to find it. Ultrasound is another modality that's used to screen for breast cancer. Breast MRI is a newer modality that's also used in a specific subset of patients. And then some women feel a mass, or a practitioner feels a mass in the breast, and then we'll kind of work backwards and get the mammogram and get the ultrasound to investigate. Now, I do separate screening mammogram from diagnostic mammogram because it is different. A screening mammogram is a mammogram that you obtain when you have no symptoms and no signs. You're doing well, you're just going in for your annual screening. A diagnostic mammogram, on the other hand, is a mammogram obtained when a female either feels a mass, has breast pain, feels a nodule, has nipple discharge. So these two are distinct when your physician orders them. So how do we diagnose breast cancer? So the gold standard of breast cancer diagnosis is an image-guided core biopsy. So what does that mean? There's 2 main ways to do it. So it's the use of an imaging modality. In this instance, it's ultrasound, and in this picture, it's mammogram. The radiologist uses the ultrasound to identify the lesion, the mass in the breast, And then a biopsy needle is used to take tissue samples. They're actually removing pieces of tissue from that lesion, and then it's looked at under the microscope by a pathologist for a diagnosis. On the other hand, if the ultrasound can't detect it, a mammogram is used, and there's a special stereotactic table. Same idea, a needle goes into the lesion, removes tissue, and then that tissue goes to the pathologist for examination. It is important to note, false negative rate. So the likelihood of this needle core biopsy being wrong and missing a cancer if a female has it is less than 2%. That's very, very good. So 98% of the time, this core biopsy is giving us the diagnosis we need. So you have a diagnosis of cancer. The cancer's in the breast. So what are the treatment options? So there's 3 main groups of treatment options for breast cancer. Surgery being kind of one of the main ones. Chemotherapy, the medical side of treatment for breast cancer, and then there's also radiation. So we'll touch on these a little bit. The main focus here is going to be the top 2. Okay, I'm a breast surgeon. I see women all the time for treatment of breast cancer. What are my goals for that woman when she comes to see me with a diagnosis of breast cancer? So the goals of surgery are a little bit different from chemotherapy and other modalities. So from a surgical perspective, the goal of breast cancer surgery is twofold. The first, remove the tumor from the breast, okay? Get the cancer out. And the other component is to stage the disease. And that involves sampling the axillary lymph nodes on the same side as the cancer, those little green channels we had seen earlier. The stage of disease has a real big impact in what we do post-surgery and sometimes even before surgery. So stage of disease is very important. There are 2 ways to get a breast cancer out of the breast, one being a lumpectomy, removal of the mass, preserving the rest of the breast and the nipple, or a mastectomy, which would mean removal of the entire breast. So this is just a quick overview, a simplified version of breast cancer staging. There are 4 stages. Fortunately, the vast majority of breast cancer that we see is stage 1 and 2, which we term early stage breast cancer. The survival for stage 1 and 2, the amount of women alive at 5 years for stage 1 and 2 disease is over 95%. It is excellent. It drops down to in the 80s for stage 3. 85% of women with stage 3 disease are alive at 5 years. Stage 4 disease, which means the cancer has spread outside of the breast, outside of the lymph nodes to some sort of distant organ. That can be liver, lung, bone, brain. The survival at 5 years is 20% of women. That's not very good. So we want to find breast cancer and treat it up here, stage 1 and 2. Fortunately, over 65% of breast cancers are diagnosed at that stage. Hence, we have good outcomes. So these stages just kind of show you, at stage 1, the tumor's small, the nodes are not involved. In stage 2 disease, the tumor's usually small and only 1 to 3 nodes harbor cancer or none. Stage 3 disease implies locally advanced disease, so more than 3 lymph nodes positive or a tumor that's large being greater than 5 centimeters. And then stage 4, I talked about spread beyond the breast, beyond the lymph nodes. So the staging categories are based on these little things that are going to appear at the bottom of the screen. T is size of tumor, N is the presence of nodes, and M being the word metastasis or spread to distant places in the body. So we're going to kind of review quickly what have we done historically for breast cancer, okay? Because treatment has changed a lot and it's in the patient's favor. So you go all the way back to 1882. The first surgery was performed for breast cancer by Dr. Halsted, and it was a radical mastectomy, and this was the only treatment option women had. They went in with breast cancer, this was it. There were no options, there was no discussion, this is what was done. So, I mean, this is an ancient picture here, but you take off the breast, they took all of the muscle, your whole chest wall muscle, left a big defect, and the skin was closed essentially over your ribs. It was very aggressive surgically, it was curative, but very disfiguring and morbid for women. So fast forward almost 50 years to 1932, that technique is revised, and we have a modified radical mastectomy. This became the new standard of care in breast cancer treatment. So how is this surgery different from the previous? Well, this one, the whole chest wall muscle is left intact, less disfiguring, and then they began to remove the lymph nodes because they found that that was important in staging the disease. So a better surgery, but still, for every woman, do they really need this? That was the question. And so people got together and said, well, can a woman have breast cancer and we just take the cancer out the breast without taking the entire breast? So a ton of research was done on that. This is just a picture of what a mastectomy would look like after surgery. It's just the chest wall and a scar. So then we get to 1985, and after much research, lots of patients, it came out that a lumpectomy has equivalent survival to mastectomy. So now a woman can save her breast. The only caveat to that is that in order for these women who save their breast and take their breast to have the same survival, mean live the same amount of time with their disease, the patients that undergo lumpectomy have to get radiation to the breast tissue that remains. So a lumpectomy is an incision at or near the tumor in the breast. You take out the tumor with an area of normal surrounding breast tissue and you close it. You keep the breast contour. You usually are able to preserve the nipple. And this is just kind of an example of what an actual patient would look like. Here's their incision, here's the nipple, and their breast looks pretty good, and they get to keep their breasts. So less disfiguring. Women can still feel like women after surgery. Now, is every single patient a candidate for lumpectomy? Well, of course not. You know, every patient is different, but the vast majority of patients in that stage 1 and 2 category with smaller tumors are candidates for lumpectomy. So this revolutionized breast cancer management, and women were able to save their breasts. So that was a huge, huge advantage. Then there were advancements in another kind of portion of the surgery. So traditionally, to surgically treat breast cancer, we remove 10 to 20 axillary lymph nodes, those nodes that are under the arm where the breast cancer drains to. Well, when you remove 10 to 20 lymph nodes, there are somewhat significant side effects that women can experience after surgery. So the 10 to 20 nodes come from these two areas, the level 1 and 2 lymph nodes, and that's just an anatomic classification for surgeons when they're going in. It's out here lateral to the pec, under the pec, and you don't take these nodes, which are medial. So that's a lot of lymph nodes to lose from under your arm. So what happens in patients who have all those lymph nodes removed from their arm? Well, you can get pain, you can get swelling. Look at the difference between these two arms. This causes a throbbing, a heaviness, decreased range of motion, morbidity for women. Also, the lymphedema can predispose you to infections because your arm can't drain good. The tissue does not drain. So if you got a bug bite or an abscess here, you're much more predisposed to infection. So the risk of this lymphedema with the previous surgery I showed you about, the axillary lymph node dissections, up to 20 to 30%. That's high, okay? So a lot of research was done, and they said, well, what can we do? Are the lymph nodes that important? Do we really need to be taking 10 to 20 lymph nodes? And so in 1992, the sentinel lymph node biopsy technique came out. And this has revolutionized breast cancer treatment as well. So this is a specific type of procedure. This isn't just going in and taking out whatever lymph nodes I feel like I can find at time of surgery. So when a woman's diagnosed with cancer, and we're going in to do her breast cancer surgery, they're injected with a radioactive substance the morning of surgery. Right before or after the patient's put to sleep, a blue dye is injected either at the nipple or at the tumor site. There's a fancy probe in surgery. Once I make an incision, I'm looking for blue nodes from my blue dye, or I'm using this little machine, and this machine makes a loud buzz from whatever nodes took up this substance. Those are, in essence, the gatekeeper nodes. The first node a cancer would drain to. If they're negative, if the pathologist sees no cancer cells on those nodes, the likelihood of any more nodes harboring disease is less than 3%. So why take them? So you take out 1 to 5, less morbidity, significantly lower incidence of arm swelling and lymphedema, less than 3%. So women get back to their activity faster, small axillary incision, you don't have to make big incisions, you don't have to leave drains, so women can feel back to normal faster. So this is huge. This is the standard of care. This is what I do on 95% of my breast cancer surgeries. So most breast cancers are small, which is a good thing, and many aren't palpable or we can't feel them on exam. So how do I know where the cancer is at time of surgery? How do I find that tumor without traversing through all this breast tissue? You don't want to play a guessing game at time of surgery. So up to really 2 years ago, we were utilizing wire localization. So the radiologists would take the woman down for imaging, they would find the lesion and literally put a wire in the breast the morning of surgery. They would come up to surgery with a wire hanging out of their breast, and that's how I would find the tumor if I can't feel it. So this, in essence, is time-consuming because you have to have it the day of surgery. A woman can't go around with a needle in their breast for days prior to surgery. There's needle dislodgement. You know, if they move or the dressing pulled, the needle could get dislodged and then it's no longer in the tumor. Well, that's not good. And it limited the surgeon. So from a selfish surgical perspective, wherever this wire is entering the skin, that's where I have to make my incision. And that might be 5 or 10 centimeters away from the tumor, wherever the radiologist had the easiest path to the lesion, which may not be my easiest path. So about 2 years ago, when I came here, I had gone to a conference and we instituted this, mag seed. This is an example of the mag seed. You see it here. Here's the cancer. This is a mammogram. And the radiologist has put this little seed right by the cancer. This is a pictogram. This is the seed. This is obviously a penny, just to show you it's about the size of an uncooked grain of rice. And it has magnetic properties. It's a fancy little expensive machine with a probe that I use in surgery, and I put it on the skin of the breast. It puts out these numbers, and these numbers are yellow, and as they get higher, that means I'm close to this seed and close to the tumor. So I can put the incision on the breast wherever I feel appropriate, directly over the site, and it gives me leeway, and I can be more precise during surgery, so I don't have to, if I know it's this deep and here's my mag seed, I don't have to excise all of that tissue. I can go down and then excise just this for my cancer operation on the breast. So this has really, really changed the way I do breast surgery, smaller incisions and more direct access to the tumor. So I take the lump out, I send it to radiology, they confirm they see this and this in the specimen, and then we're done from the cancer surgery on the breast and a lumpectomy. So then we come across situations like this. Most lumpectomy patients do well. MagSeed has allowed us greater leeway in placing incisions and making the breast look nice. Now, is cosmesis my first concern? No, it is not. It's the cancer part of the surgery, the oncologic surgery, negative margins, adequate staging. But women are living with breast cancer, right? Their survival's 90–95%. So they're alive at 5 years to see themselves in the mirror. And when they wake up and they see themselves in the mirror and their cancer breast looks like this, they may not be happy with that. And so then, now we're getting picky. Women are doing well, surgery's going great. So 21st century, we start thinking about oncoplastic surgery, meaning cancer surgery with the plastics part, trying to make it look good. So oncoplastic surgery is just a term for a type of technique or procedure that maintains the principles of oncology. You're still getting negative margins, you're still getting the tumor out in an oncologic fashion, but you have enhanced cosmesis. Incisions maybe that aren't so obvious if you're able to put them around the nipple or in the inframammary fold. And then after you take out this big chunk of tissue, closing that defect, reapproximating that breast tissue to make it look nice. And then when appropriate, involving a plastic surgeon for a concurrent or at the same time breast reduction, lift, or something cosmetic. Is every single patient a candidate for this? No. But it needs to be in your toolbox to offer to patients for whom it is appropriate. So then in the 21st century as well, more recently, we have when women do need their whole breasts off. If a woman does need a mastectomy, we have nipple sparing techniques that plastic surgeons can do immediate reconstruction right then and there. That can be implant-based, that can be flap-based, and what I mean by flap is your own tissue. So there's two ways to reconstruct, speaking very, very generally, and that's either implants or flaps. So now women have options. You know, I can't think of many other cancers where I sit and give options to patients. When I see a colon cancer patient, I don't ask them what segment of colon, do you want your right or left colon out? You get your right, wherever the tumor is, that has to come. And the same is for lung, for most cancers. But for breast cancer, we sit in front of patients and we say, do you want to save your breast? Or do you want a mastectomy? Do you want reconstruction? Do you not? Does every single patient get all those options? No, but most patients do. The early stage breast cancer patients, I'm giving them options. And it can be a little bit burdensome because, you know, I think the knee jerkers will tell me what to do. I don't know what to do. But what a great thing that we give, that women actually can have the option to participate in what kind of surgery they're going to have for their cancer. So I think it's a good thing. It can be stressful to decide what you want to do, but I think it's good. So 62% of breast cancer is diagnosed at an early stage. That means it's limited to the breast. 99% 5-year survival. That's great. Even at 10 years, it's over 90%. So women are living with breast cancer, right? So in 2018, our staging changed. We started to realize that size isn't everything. The size of the tumor doesn't exactly always predict behavior. You would think bigger tumor, more aggressive. That's not necessarily the case, okay? And so through a lot of research, this all came to be that tumor grade, what these cells look like under the microscope, is actually very important. So this is just a kind of an illustration of what it would look like under the microscope, except for nice and pretty and colored. So these are all cancer cells, but these look very organized and they don't look very disrupted. And as you head to the right, they look uglier and uglier. So this would be high grade and this would be low grade. All cancer is aggressive by its nature, but all cancers aren't created equally in the breast. And we started to realize that. Why do some tumors that are really small behave very aggressively while this 5-centimeter tumor is not? And so more research, more advancements. Now every single tumor is tested for these 3 things. This is just a name of we call them receptors, but these are the 3: progesterone, estrogen, and HER2/neu. You might say, what are those? Who cares? Imagine a breast cancer cell, and there's these little things on the surface, right? These are receptors, something that a normal breast cancer cell may or may not have on their surface. Then you see a cancer cell, and it is just overgrown with these receptors. So what that implies to us is that, well, this specific tumor that's covered with the estrogen receptor, maybe it's responding to estrogen. So maybe we need to block a female's estrogen to prevent recurrence or slow its growth down. If these receptors are all these HER2/neu receptors, maybe we can find a medicine that blocks only that to shrink these tumors down and treat them. So that's what was done. There are 3 big categories of receptors, and I say this not to get into the nitty-gritty of breast cancer, but if you have breast cancer, I'm talking about this with patients because it's very, very important. So you have the big heading of breast cancer. Now we subtype breast cancer into 3 main categories, and it's hormone receptor positive, HER2/neu positive, and triple negative. And this gives us an insight into tumor biology. How is this person's tumor going to behave? And do we need to treat these 3 subtypes of cancer differently? And the answer is yes, we do treat them differently to a certain extent. So women with the estrogen receptor positivity are going to get medicines to block the estrogen, tamoxifen, aromatase inhibitors. Women who are HER2 positive are going to get a medicine called Herceptin. And then the triple negative portends a more aggressive subtype of breast cancer for which usually traditional chemo and surgery are the only options. So what we found, like I've alluded to before, is that tumor biology, the way the tumor is behaving under the microscope and these receptors, plays a very important role in cancer treatment. And that size, although in the staging and a very crucial part of it, does not always predict what a cancer is going to do in the breast. The nodal involvement, the nodes under the axilla having or not having cancer is important, but more prognostic now that we find more and more tumor biology is reigning supreme here. So we're using size and nodal status, but now newer methods to try to identify tumor biology features are becoming very, very important in the way we treat breast cancer. And it's a good thing. So targeted therapy, traditional chemo. You take healthy cells, you give them chemo. Well, these cells are going to die, and then these cells are going to die. So these are your normal cells. Well, we want to kill these guys. We want to kill the cancer cells. But traditional chemo, I'm simplifying this very much, but traditional chemotherapy aims at killing rapidly dividing cells. So cancer cells are rapidly dividing, but other cells in your body are rapidly dividing too. For instance, hair cells. So that's why women lose their hair for chemo, because there are side effects. The chemo is hurting other cells in the body. That is less than ideal, but that's what we have to treat the disease. So chemotherapy side effects are from healthy cells dying. So now we still give traditional chemo. It is still a cornerstone of management of breast cancer, or a component of. But you take immunotherapy now. That HER2/neu I talked about, here's actually a picture of a cancer cell expressing these HER2 receptors. Well, this medicine, Herceptin, it only blocks this. It only kills cells that are expressing this. So when you get Herceptin, it is more likely to just kill cancer cells than it is to kill other cells in your body. Now, unfortunately, the only patients that can get Herceptin are the ones that are HER2 positive. But that's where breast cancer treatment is going. Targeted therapy. We don't want to kill normal cells. We want to kill cancer cells only. So with that, with the ability to target breast cancer cells or breast cancer receptors, we can use these therapies sometimes preoperatively. And we can use them to downsize tumors. A woman with a 5-centimeter tumor in her breast with axillary disease, maybe we can give her medicine up front to shrink the disease so that we have to take out less tissue at surgery. And a woman that maybe couldn't have breast conservation can now have breast conservation because we have these medicines that we can use before surgery instead of going straight to surgery. So here's just a sample patient just to illustrate the point. 55-year-old female, she comes in with a 4-centimeter breast mass, core biopsy done, it's biopsy-proven cancer. She wants breast conservation. She doesn't want to lose her breast. But look, she's an A cup. She's got a 4-centimeter tumor. That's not going to look good, okay? But look, her receptors came back. She's HER2 positive. So can she undergo lumpectomy? She could potentially have a very pleasing cosmetic result if she gets Herceptin and this shrinks down. You shrink this to a 2-centimeter tumor, you probably wouldn't even know she had surgery after a year. So now we're utilizing these medicines that were never available before. And now they are. And women who might have been obligated to a mastectomy, losing their breast, can now save their breast. And that's a discussion with the patient, but now we have options. So who needs chemo? You know, the vast majority of breast cancer is diagnosed at an early stage. So do all those women need chemotherapy? If they're living 5 years, their survival's great. And so then the school of thought is, well, tumor biology is very important. So for these small tumors, patients with 3 nodes or less that show cancer under their arm, that are hormone positive, these patients tend to do very well. So they started to think, well, maybe, do they need chemo? Do these patients need chemo? Can we omit chemotherapy in a subgroup of patients? You don't want to withhold chemo from a patient that's going to benefit from it. But if you give chemo and the benefit is very, very small and they're going to do well otherwise, is it really worth that toxicity, all of those side effects? So the advent now of a special predictive assay, these are 2 different companies, 2 different types, there are more, but these are the main ones. Now we have the ability to send tumors for this testing. So what do? Well, they're genomic based. They take the actual tumor, the nodal status, the receptors, and it goes into this big complex algorithm, and it shoots out a score. And that score says High risk or low risk? What's the likelihood that this cancer is going to recur with or without chemotherapy? So to illustrate that, here's a sample report. This is the report this is an Oncotype DX report. So we send this after surgery or sometimes before, and we get a report. And this would be the patient's name. This is their report. This is not a report on anything else but that specific patient. So very, very individualized treatment here. And their recurrence score is 10. So anything less than 25%, or not 25%, anything less than the number 25 is considered low risk. So this patient would not be offered chemotherapy. How wonderful. She might have had a 2 to 3 centimeter tumor, but her tumor biology says that chemo really isn't going to have a benefit. So why put that patient through the toxicity? So 10, 15 years ago, if your tumor was greater than 0.5 centimeters, you're pretty much getting chemotherapy. But now we're saying size isn't everything. Even nodes isn't everything. So the combination of size, stage, nodes, and now this tumor biology type of test can save some women chemotherapy, which is life-changing for those women. Now, unfortunately, there are those patients that come back with this. So this would be a high-risk score. The benefit of chemotherapy is over 15%, but at least a patient can look at this report and put some numbers with what they're about to undergo. They can actually comprehend, okay, I need chemo, it's 6 months, but look, I've got my risk without chemo is way higher, so chemo's gonna benefit me, and you can kind of wrap your head around needing that. And I think it helps patients understand why we're giving these medicines instead of just throwing the kitchen sink at everybody and saying, oh, well, let's just give chemo because certainly it might help. But in some patients, it's not going to do very much. So I think that's a wonderful adjunct to breast cancer treatment. There are those people, there are those women, those cancers where this test isn't even applicable. I mean, if you have high risk, locally advanced disease, we're not going to send this test because you're going to be a candidate for chemotherapy. But like I said in previous slides, the vast majority of breast cancer is diagnosed early stage, good outcomes, good prognosis. So if we can save even some women chemotherapy, I think we call that a victory. So what's new in imaging? That's what's new in surgery, sentinel node, less invasive surgery, trying to make it look good, wonderful reconstruction techniques for those women who need to lose their breast. So in imaging, our screening modality is very important. We don't want to miss breast cancer. So 3D mammogram, most of the mammograms, at least in this town that are done, are going to all be done with 3D. And so I'll give you an example. This is your traditional 2D mammogram. This is kind of what it looks like. It's only 2 views, one coming from the top, one coming from the side. And on a 3D mammogram, you have almost these slices through the breast where things can be picked up better by the radiologist looking at the film. So what this results in is less callbacks for, oh, hey, we saw something on your mammogram, we're not sure what it is, come on back, and we'll repeat your mammogram, which how many women want to go back for a mammogram? I mean, I would say 0. You know, it's not the most comfortable thing. So the 3D mammogram does decrease the need for repeat imaging. It also has a better sensitivity in dense breast tissue. So dense breast tissue, you know, inherently is the X-ray, that's all this is, it doesn't penetrate through dense breast tissue as easily as it does fatty tissue. So women with dense breast, a 3D mammogram is better for that. So this shows you kind of the difference. Here's a 2D mammogram, and you can maybe see the lesion, but look on the 3D. It's very obvious. There's a spiculated mass, very suspicious. This would probably have resulted in a callback with more views and smushing. And then this, you go straight to ultrasound guided biopsy. So if anyone has ever experienced an abnormal mammogram or ever experienced the need to get an ultrasound and get a biopsy, it is an anxiety-provoking situation. And unfortunately in medicine, things don't just happen overnight. So you get your mammogram, then they have to tell you it's abnormal, then they have to schedule you for the repeat mammogram, then you have that, then that comes back abnormal, and it's this long drawn-out process. So if we could do anything to smush that process and get women a diagnosis or get them reassured sooner, then that's a big feat, because I'll tell you, most women who have gotten that letter in the mail for an abnormal mammogram, it is very unsettling for them. And really, in your mind, it is cancer until proven otherwise. That's how most women think. Some maybe not who have had it before or had a history of fibroids and fibrocystic disease. But for most patients, if your doctor's calling you or you're getting that letter in the mail saying that you have a suspicious finding on your mammogram, the things that run through your head aren't going to be very good. You're going to be thinking cancer. So the faster we can either diagnose it or prove that it's not, the better for women. This is just an example of an MRI of the breast, not indicated for general screening of the regular population, but certainly indicated in high-risk populations, women with significant family history of breast cancer, possibly history of surgery in the breast. But this shows a mass in the breast on MRI. MRI, by default, always images both breasts, so you don't ever get a right or left breast MRI. It's you're lying prone, tummy down on the table, and it's always going to image both sides. It is expensive, so it is not reasonable for it to be a screening test, but it is good in a certain subgroup of patients. And that's for your doctor to decide. It's not anything you would really order, as a screening test. So now we have a good screening test. Mammogram is doing well, but what about those patients with significant family histories? What about those patients who you feel that are at higher risk than the average population? So this is where genetics and high-risk breast management comes in. The goal of programs like this is to identify a subset of patients that are at elevated risk for breast cancer. Well, who are they? How do you know if you're at elevated risk? Well, risk assessment tools. A primary doctor can do it. I do it for pretty much any patient, any breast patient that walks in my office is going to get risk assessed. So last year's lecture was about risk factors for breast cancer and when are you at high risk and things like that. But family history, age, not ever having children, the use of hormone replacement, all these things elevate your risk. Family history and age predominate. So your genetics and elevated age obviously are probably the two biggest. So genetics is testing your DNA for specific mutations. And those mutations, BRCA1, BRCA2, there's a whole slew of them. If you are positive, there are specific management changes. We treat these women very differently. They go on, like Angelina Jolie, to have prophylactic mastectomies, meaning surgery before you get the cancer. So here, stuff like this is aiming to not so much find cancer before it develops, but identify those patients that are at such high risk that they warrant a very aggressive surgical approach so they never get cancer in the first place. How cool would that be for someone to intervene and keep you from getting cancer? So obviously taking both breasts off of women is not ideal, but if your risk is 80% that you're going to get breast cancer by the age of 60, I think there'd be a lot of women who would consider that, and that's just what this kind of testing does. Also for ovarian, meaning prophylactic removal of the ovaries and those who are at very increased risk for ovarian cancer. The list goes on and on. Not everyone needs to have their genome tested, but when you're getting evaluated from an annual exam for breast, or you're seeing a breast surgeon, a risk assessment is a very important part of that process, and finding out through a family history if you warrant genetic testing, and that's something that should be done in conjunction with obviously your physician or provider. And it's becoming more and more common, and it's a buzzword now, and this is probably in the past 5 or so years, because when I was in training, I tested nobody. I never did genetic testing. And here I am, and I send at least 3 a clinic. So I'm sending almost 3 to 6 a week just here, and I'm just one physician. So this is just an example. BRCA1 and BRCA2 are the big breast cancer genes. These are some of the other common ones, and when you get genetic testing, this is what they're testing for, specific mutations in our DNA. And if you have these mutations, all of them have specific management protocols where for BRCA1, the risk of breast and ovarian is extremely high, and we would consider, setting women up to discuss mastectomy or risk-reducing agents. And these are all just examples of genes that are associated with an increased risk of breast cancer, much higher than age would ever, be for somebody. So if we find these, then we can really intervene in a timely fashion, and hopefully a woman wouldn't get breast cancer. I will say that in general, less than 10% of patients test positive. So less than 10% of breast cancers, if we tested all of them, are going to come back positive. But those 10% that do, it's a significant game changer, even for their family and their relatives, their daughters, their siblings, if they're positive. So how far have we come in breast cancer treatment and management? Well, we have better imaging, so we're able to find breast cancers earlier. We now can breast conserve or not have to do mastectomies in a large subgroup of patients. The vast majority are candidates for either. We have very complex reconstructive breast surgery options. That's all done by plastic surgeons, of course, and that's a whole lecture in itself. It's amazing what they can do. You know, in women who need mastectomies, either for BRCA1 or for locally advanced disease, what they can do to reconstruct a breast, it's pretty amazing. Hormonal manipulation, being able to give those medicines that target those estrogen receptors, it reduces the risk in women by half. I mean, it's cutting women's risk of recurrence in half. And these medicines can also be used in our high-risk population, that your risk is 40% over your lifetime you're going to get breast cancer. Let's manipulate your hormones. Let's give you tamoxifen. Let's give you these medicines, and then your risk decreases in half. Now, those medicines have side effects. That's a whole lecture in itself as well. But we have options now. We have options to reduce women's risk. We have sophisticated radiation techniques. I'm not an expert on radiation, Dr. Mays is, but the stuff they have to do whole breast radiation after lumpectomy is pretty amazing with how they can target the tumor bed and things that are done to reduce the side effect profile of radiation, which is disfigurement, burning, skin damage, trying to get to the tumor bed itself and not so much the skin. Then we have these predictive assays, that Oncotype, the MammaPrint, and that's really letting us individualize cancer care. How cool is that? You know, I think that's just amazing. Targeted therapies, Herceptin, trying to kill just those cancer cells, targeting therapy to the cancer cells only instead of killing all the cells. And then, you know, we have great outcomes. You know, fortunately for breast cancer, women do well. There's over 3 million women in the U.S. living with breast cancer right now. And so that's a good thing in the sense that these women are surviving. And all of the data and all of this, you know, the hormones, the predictive assays, they're able to come up with these treatments and Herceptin because of the large number of patients we're able to study. You know, when cancers are uncommon, it's very difficult to get enough data to really study therapies. But breast cancer is very common. I mean, you saw the number, 270,000 cases a year. And so there's a lot of patients to be able to study, and that's why we are where we are now. So breast cancer is treatable and curable. Yes, you have to undergo treatment and surgery and potentially chemo and radiation. Treatment is becoming more individualized, which is a good thing. Early detection of breast cancer remains at the forefront in diagnosing early stage disease. The vast majority of what I see in my practice is a woman feels great. She doesn't have a pain, she doesn't have a mass, she doesn't hurt, she hasn't lost weight, she had an abnormal screening mammogram and it's cancer. So the vast majority, that's when we want to see it, because usually that means it's early and it's very curable at that stage. Like I just mentioned, over 3 million women in America are living with breast cancer. Better imaging, less aggressive surgical options, tailored treatment regimens is how we practice now. I will say I'm one part of breast cancer management and treatment. It is a team approach always. It is almost never or never should be one individual in charge of your breast cancer care. It is surgery, it's medical oncology, it's pathology, radiology, radiation oncology, and that group of collaborative physicians is the reason breast cancer is the way it is now, because it's important. Everyone's role is important in getting a cure for breast cancer. Can Memorial fulfill the needs of breast cancer patients? You know, a lot of patients I see say, do I need to go to MD Anderson? So I put this slide up, you know, do I stay or do I go? But the answer is yes. Are there those patients who are out of our scope of practice? Sure, it's rare though. This is what we have here at Memorial. Surgeon, breast specialist. We have wonderful radiology. Our interventional radiologists, I'd put them against anyone in the nation. I mean, they're excellent. Medical oncology, radiation oncology, our cancer navigation process, and now new to our little family is clinical genetics. You know, we have a genetics program. We have a genetics educator. We're testing women more, and when we're finding positive results, we're getting them where we need to be. We're navigating them to the specialists they need and involving their families so they can know if they're at risk or not. So the answer is yes, we can provide, I think, very good care here, and I would put our care against MD Anderson. I would put it against any major cancer facility. What do we not do here is complex breast reconstruction. That's what we're missing. And that isn't most patients. You know, most patients don't need that right off the bat. So I think we are able to keep patients here and do a very good job. Thank you. I'll take any questions.